I'm really sorry, everyone. Yeah, we're recording, so I'll...
Lovely. Okay, thank you very much. Welcome everyone to this board meeting of Sussex Partnership NHS Foundation Trust. My name is Peter Molyneux and I chair the Trust. You're all very welcome today, those of you present in the meeting and those of you who may be watching online. Apologies for absence. I have apologies for absence from Professor Carrie Llewellyn, and I have no additional declarations declared. Does anyone else have any interests to declare that haven't previously been declared? No, thank you. Minutes of the Board of Directors held on the 31st of March. Can I take them for accuracy first? Are people happy to approve those? It appears that we are, so those minutes are approved. We've had one question from a member. Sorry?
The accuracy, it's Anne.
Oh, hello.
So, sorry, it's just two words that were missing from my contribution on page 4. It makes a lot more sense if it reads, what influence do we have on the feedback that links directly from the programme of improvements in order? So it's just 2 words I think were missing that make my contribution a little bit more sensible.
Okay.
Thank you.
Thank you. We'll make that addition. Don, were you wanting to come in or are you just off mute? Fine. Akosia, are you wanting to come in?
Yes, please, Chair. Just to say that in the those present, I'm not listed. I was at the last board meeting, so we might just need to amend that.
Certainly, absolutely. Thank you. Any other amendments to the minutes? Rick.
Thank you, Chair. I think there's a note about the last board development session. I was there and I'm not on the list. Okay. If I could be added, that'd be great. Thank you.
All right. Anyone else feeling cruelly left out? No. Okay, great, good. Good importance to get those things right. My sense from the action tracker is that we're up to date on the action tracker. Anyone demur from that? No? Okay. So we then move to, we've had one question from a member of the public, and it relates to our conversation and discussion about the impact on the overall system pressure on young people, their families and carers, and how we collectively respond to this and mitigate risk to young people. And the specific question refers to a situation where a young man has been waiting for 2.5 years for a stage 2 HDHD assessment. And the member of the public is asking, how is the risk to that young person and the other young people on the HDHD pathway being mitigated when the HDHD service is not commissioned to offer reviews and support to those not already on medication? In other words, if they're on the waiting list but have not been given medication, he's saying they receive no support. I mean, I think that's a really important question in terms of bringing, to very real life, the experience on the front line of the pressures we were discussing when we talked about the CAMS pathway. Stanley, I think I'm asking you to respond to this. Is that correct?
Yeah, happy to do so on that. So, I mean, I think the point you made, Chairman, it's really difficult for families who have their children waiting for ADHD assessments. We've got a duty system in place to monitor children and young people on the waiting list in order to determine whether there is a clinical need for them to be seen more rapidly so that we can move people through the waiting list more quickly if their health deteriorates. We also provide families with information about additional sources of support which can be available whilst they wait the appointment. That said, recognise that there is much further work needed in terms of increasing capacity within the service to reduce waiting times. especially given the significant increase in the need for specialist mental health support that we're seeing in our local communities. We, as part of the long-term plan for mental health, we've secured significant investment from our commissioners over the years ahead. And we are putting together work around a business case to specifically focus on this particular area.
So what sort of timescale are we talking about in terms of when might that be achieved, but also when might we start to see those waiting times come down?
I think realistically we're probably talking nearer 6 months in terms of the start to see the implementation of that, and starting to see some impact from that work. I think it will certainly be at least 6 months until that starts to happen. Once we have the agreement around the business case, the work that needs to be done, and then obviously appointing into that and getting that started even on an interim basis. So I think we're talking about that sort of time frame.
Okay. So I think perhaps, Sam, I think it would be good, I know you've been in touch with the family who raised the question, and clearly I think it would be good if we could go back to the questioner and just explore a little bit about their experience and their perception that support is not available to them. And then I think, Stanley, I think in terms of the timescale you've described, this is obviously something we'll stick on the actions tracker to come back to, because our sense is that, of course, the potential pressure on services and the potential demand is quite likely to rise over the next 6 months to a year. And we need to make sure that we're able to cope with that additional demand, aren't we?
And certainly our local general manager will be making direct contact with the family in relation to this case. Yeah, we've already agreed that.
Because I think there's the presenting issue for the family, but then there's obviously the bigger issue that's being referred to here, which we need to track as a board. Are you happy to move on from there for today? But we will we will make sure we keep on top of this, both for the individual concerned and the wider issue. But thank you, and that's encouraging, Stanley. But let's hope that that's a long timeline rather than an optimistic one.
Chair, if I may just add briefly, this has been an issue that's been on our risk register for a while. It's a situation that our service have identified over a period of time, and Stanley said the business case has been put to colleagues within our integrated care system. They have supported that now, which is really positive. I just thought it was important for us to be really clear about that in terms of all of us acknowledging and accepting this as an unacceptable position, and the work of the service who've been working hard to address that.
Good, thank you. We had no other questions from members of the public, so we'll move to the Chair's report, which I'll take as read. Are there any questions on the Chair's report? No, okay, thank you very much. Move to the Chief Executive's report.
Thank you, Chair. I'll take the report as read. There's a couple of attachments to the report today. We are asking for the board's support to approve the statement that we've appended, our trust statement regarding modern slavery. It is a requirement of all organisations to publish their own statements on their website, and I would propose that we adopt this statement as a board and publish it on our site. It is a statement that's been developed through our Equality and Diversity and Human Rights Steering Group, and also supported by our Executive Management Committee as well, and really sets out our commitment alongside all other public sector and statutory organisations to eradicate modern slavery and human trafficking. And I think whilst it may feel odd, organisations publishing statements such as this in 2021, this is a very live and serious issue. And as a trust, we would seek to use our safeguarding processes, our recruitment practices, our training and support to our staff, particularly through raising awareness of this, and indeed the relationships we have with our contractors and suppliers, to do everything we can to be part of eradicating modern slavery. And equally, we know the real impacts that will be shown where people are victims of this on their mental health. So it's a really important commitment for us to make as a board. Chair, if I may, I just want to sort of draw out a couple of things in the report. The first, I just want to really commend the nurse education team and our partnership with the Met College in launching the first Health and Care Academy across the South East. This is a really, really good development. It provides an access course of 16 to 19-year-olds who will undertake work placements in Millview Hospital and Meadowfield Hospital. We will, as we get into our integrated assurance report, we'll be looking at things such as workforce. So we know the pressures we've got in terms of both recruitment and retention. And I think particularly following the year we've had, to be part of encouraging younger people to consider a career in the health service and indeed mental health and learning disability services is a really positive thing. This is something we really want to build upon. My thanks particularly to Professor Anita Green in Ecosia's team for that development. The second thing I want to just draw attention to, you'll recall in my last report to the board, I mentioned the CQC inspection at Langley Green. I'm pleased to report the CQC have returned and re-inspected Langley Green and have confirmed that they are pleased with the improvements that we have made, and we'll be looking, working closely with the CQC at the moment, and we expect the report on that service to be published next week. I think what this inspection, the two inspections, have really demonstrated to us has been the real emphasis and focus around physical health assessment, care planning, and also that ongoing support to our leadership teams across our acute inpatient services on supporting them to maintain the basic standards that we've got in place, notwithstanding the increase that they're experiencing at the moment in acuity. And that leads me on, Chair, just to really mention the point I've made in the report around what we're really seeing at the moment, which has been some quite significant demand for presenting for children and young people into our services, and particularly across our eating disorders pathway and the work we have underway across our system at the moment, both in terms of addressing those needs in the pathway and at a regional level, particularly around capacity in CAMHS Tier 4. We do know that there are some particular issues exacerbating the pressure around capacity, not least the closure of some children and young people's services. And we're working in our lead role through our provider collaborative with all of our partners to look at what remedial actions we can put in place. And one of those, Chair, is a conversation we're having at the moment. It's more than a conversation, a piece of work that's clinically led. Rick's leading that from our side of things, working with our system partners on a more integrated physical and mental health approach to eating disorders within local services, which I think if we can achieve that, that would be a really positive thing. But we are certainly feeling the pressure, and in particular, obviously, our young people, their families, and indeed colleagues working across those services. And then just finally, I just want to mention two things with regard to changes in the executive team. I want to congratulate Beth on her appointment as the Chief Digital Information Officer at Strathclyde University. Beth, I think this will be your last Trust Board meeting. You've been with us 3 years now. We're delighted to see you go on and pick up a career in academia up in Scotland. And just to share with the board that Dr. Gurpreet Panu, who's our Clinical Chief Information Officer, will be picking up the reins from Beth over the next year as CDIO. And I also want to just acknowledge that this will be Ecosia's final board meeting with us as well. She's transitioning to her promotion into the Regional Chief Nurse's role. Colleagues will be aware that we have appointed our new Chief Nurse, Dr. Jane Padmore, who starts with us on the 16th of August. And in the interim period, Justine Ross, our Deputy Chief Nurse, will be acting up. Thank you.
Thank you, Sam. So that's a really helpful overview. I'm conscious you made reference to the CQC and Langley Green. I suggested people have questions on that. We pick those up under the Quality Committee report and keep that in one place. But do people have questions for Sam on any other parts of her CEO report? Anne, please, and then Anna.
Yeah, I just wanted to make the point, Sam, that over the years, I've always been disappointed that service user-led kind of groups such as Emergence have disappeared. And since their disappearance, I'm seeing the re-emergence of things like day hospitals to support people who have eating disorders. And I wonder, how are we including people when we've got huge capacity issues? There's a sense of urgency, an increase in demand on our services. How are we involving people who have eating disorders? Because I've never met people with that issue who've ever said that a day hospital is what they want. Is the day hospital really part of the money that we have? Is it part of what we have to provide to get the money from NHS England? Or is there something we can do, not necessarily about the model, but how we discuss this in public as a support mechanism for younger people? So does it have to be called a day hospital, or does it have to be because NHS England won't give us the money? If we don't have to call it that, can we be involving people in how to describe that support that they're needing?
Yeah, I would probably defer to Rick, our Chief Medical Officer, on this one, Anne. And actually, day hospital probably isn't the right term. It's a day service, and absolutely we'd be involving people who use services in naming it. And there's no prerequisite from anybody about what we call these services at all. But Rick, did you want to add to that?
Yeah, thanks, Sam. A really good question, Anne. I mean, Sam's right. It's not a day hospital, but it's a daycare service. And actually, you know, as we develop our eating disorders, the most progressive services will have a daycare service as a step up, step down in order to manage primarily the physical health component of people with eating disorders and prevent admission, be able to assess really quickly with that expertise on site. We're doing something quite innovative in this project as well with primary care, linking with GPs and building a hub and spoke model out into the community as well, so that people won't necessarily even have to travel to a site to get that daycare and those assessments, but the site would travel to them. The question about co-production is really good as well, and we're liaising with, we've got our own group, Download, in Sussex partnership, and I'm going to be working along with them as much as I can. Given the pace we're developing at, I actually asked the same question that you've just asked in a meeting today, and was reassured that we could get some meaningful co-production even in the short term whilst we're sketching this proposal out. Really important early on. That's why with groups who are already in existence, like Download, we can go to them, we can consult and ask for their input, and then as things develop, get more co-production along the way, especially from other young people specifically with eating disorders and their families as well.
So is that assurance that there will be co-production?
Yes, absolutely.
That's great. Okay, thank you. Just wanted to check. Thanks. Anna.
Thanks, Chair. Sam, I hope you don't think I'm being too much of a pedant, but I was just reflecting on Appendix 2 on the breakthrough objectives information, and I suppose it was, for me, this was more a question about presentation and who, you know, and I suppose the question is, who's this document for? So I just wondered whether the first page, we slightly lost our connection with the driver diagram because we've kind of turned it around the other way. And we talk about 3 strategic goals: people, prevention, partnership. But actually, I wonder if it's 3 goals that relate to those 3 areas. I don't know. I just think there's a language thing there that maybe it has the potential to kind of confuse people who are looking at it for the first time. And then on the other, I wondered on number 2, where we're talking about children and young people breakthrough objectives, whether people would know what the metric meant. So you've got 8.6% of the 2016 ONS live birth rate accessing services. So I have a vague idea of what that means, but I'm not sure that it would be meaningful to everyone, even what ONS refers to, although of course we hear about ONS all the time with the pandemic. And the last thing, which again is about a kind of, I suppose it's about accessibility issue for me, but it's a bit more than that, is as whether the metrics that we've got on page 4, so we've got reduced number of incidents relating to medication management. And my question is, and it's genuinely a question, is are those sorts of metrics specific enough to be useful to people? I mean, we say we want a reduction, but do we need to say anything more? So it was just a comment really on what's in that document.
Okay, do you want to respond to that, Sam?
Yeah, so first of all, definitely don't think you're being a pedant at all, Anna, and really welcome your reflections here. This has really been targeted at an internal audience, and absolutely appreciate the use of acronyms, you know, particularly for the public. You know, ONS can mean a number of different things. We'd want to be avoiding that and really simplifying it. And I do think there would be a more public facing version of this, which actually, to refine it, could be supersede the internal document that we've got. I think your challenge on the metrics around the introduction of the electronic prescribing system are useful as well. And I think that we could be a bit more targeted and specific about those, and very happy to look at those again.
Thanks, Sam.
Okay. I wanted to follow up, if I may, Sam, because I think the point about the metrics is one which we will need to constantly refine, won't we? And we'll get better as we go along. I was also struck. I think it's really good that that the board focuses on the breakthrough objectives, and that's where its energy is focused, both in terms of both the delivery of those objectives and the risks to those objectives. What I think we may not need to do as we move into the year is be clear about which of the metrics are about delivery and which are tracked through the executive management team, and which ones are about quality and need to be tracked through the Quality and Safety Assurance Committee. And we may just need to overlay those so we're tracking the different metrics through our different governance processes. But I think having it together like this is incredibly helpful, and it's a comment about further development, not a criticism of how it's laid out at the moment.
Yeah, no, absolutely appreciate that. And I think particularly given this year being the year it is, Chair,
yes,
and Board, particularly around the recovery phase following COVID, we'll certainly keep this under review. And I think, you know, as a learning organisation, we'll seek to continuously improve it. But we will also be needing to also perhaps revisit and adjust this as we go as well, depending on what the year ahead has in store for us as we recover from COVID-19.
Lovely, thank you very much. So we note the key achievements. I think let's notice that the key achievements at the end of Q4, it's a bit of a cliche, but given the year we've just had, I think the fact that we're able to show that level of delivery against the breakthrough objectives is really to be welcomed, and we really congratulate you, Sam, and please pass on congratulations to the relevant teams. It's really good to see the breakthrough objectives set out like this, and we look forward, as you say, as you slightly refine the metrics to seeing how we're going against those. But there is something about the presentation that I know you said you'll just revisit in terms of the external communication and making sure that we don't, the risk I suppose is we end up with a slight proliferation of objectives, and we want the driver diagram to show that it's all connected, don't we? We don't want there to be a confusion about the direction of travel and the goals, but I know that's something you'll keep under review. Is there anything else you would and then, as I say, we'll pick up on the CQC and Langley Green later on. So thank you very much. Was there anything else on the Chief Exec's report before I move this?
No, Chair.
No, okay, thank you. So can I now move to community transformation? So this is so as we said, we are focusing our energy on the breakthrough objectives. And what we said we would do is at each board, we would take one of the themes of the breakthrough objectives and actually just do a strategic review on where we've been, where we are now, and where we're trying to get to, and how we're mitigating the risks to the delivery of that thematic area. And the first one we're taking is community transformation. And I noticed that one of the things we are asked to do is to discuss the plan's model and the principles underpinning the new vision. So I very much encourage you to focus the report on the model and the principles. Stanley.
Okay. Pete, thanks very much indeed. And in some ways, it's a sort of quite a natural lead in from the breakthrough objectives into the paper.
That was the plan.
On that, it's working. I guess this, just probably to make the point, this also follows on from board discussion previously, so which we've had also in terms of Council of Governors and discussions that we've had there as well, and previous paper to the board. I think it's probably also very timely now, obviously, in terms of, as we've, April and early May was all about planning and sorting out the funding streams and that. And so in some ways, it's good to see the solidness now of this fitting in with the sort of annual planning, because I think leading up to here, there's always been a sort of, we're anticipating, but we're not quite sure that we got the money, so that's good to see. I think the paper gives an update on very much key elements of our approach, and sets that out. It sets how we're linking that to breakthrough objectives, as I said, but also one of the things that's developed over the last couple of months is very much about how we are going to manage this within SPFT. So this is very much, there is, the wider implementation of the long-term plan is something that we're doing in collaboration across the ICS, but we also need to be very clear on what is the SPFT aspect of that, and the Trust is setting up its own strategic transformation and mobilisation board to support that. I sort of broadly describe the relationship between SPFT and the ICS in relation to this as a semi-permeable one, so that there is flow, but there is some distinction between our roles here as well. I think the paper also helps in terms of setting out many of the interdependencies, and I think further work is needed around that, but also around timelines as well. On that, we've set out in the paper sort of some high-level milestones, and we've probably gone into too much detail a bit on that, but it gives a sort of flavour of the work that's emerging in terms of meeting that. Not only in terms, I guess, the first theme or the first of our breakthrough objectives around the broader community transformation, but I think it also very much ties in with some of those other breakthrough objectives that touch on workforce and other issues. And if you look at the risks and issues that are identified in the paper, very much the challenges around not just workforce but change management, the legacy and impact of COVID, both past but also COVID future demand, and then challenges in terms of both our capacity and expertise to deliver that, and underpinning that is a requirement around us ensuring we have the right demand and capacity. I know in terms of sort of bringing it back to some of the starting point, and we had this discussion about reaffirming and reasserting the vision that we are trying to achieve in this paper, and maybe pick up some of that in questions and comments. I think in terms of, and the point was made about the, if you like, the Trust's overall strategic framework around sort of people prevention and partnership, and I'd probably just want to sort of try to link this the transformation to those goals really. I think the people bit, what do we want to try and achieve? Well, we want people to feel supported, that we want them to feel valued, and we want them to feel cared for, and that they are equal partners in the work that we do. And I think that the model and the approach that we're adopting here I think very much reflects that, and endeavours for us to link that in and to do that much closer to home of people as well, and much more input and support for people in terms of how they navigate and work their way around services as well, being a sort of key theme around that sort of real people focus. I think then in terms of the sort of broader prevention aspect, you know, it's themed through many aspects of our work in the organisation, but anything that we can do structurally to better link physical and mental well-being is really important. And I think that trying to ensure that we have a model that connects people far better, that supports them more locally, that stops them automatically being taken out of that local network is really important, and I think consolidates and keeps people's well-being. So I think that the model of strong focus in primary care, working with third sector partners, trying to ensure that people get the care where they are rather than them going into secondary care services and not always coming back as timely as they should, is really important. And then I think just picking up on the partnership aspect of this, and this is sort of fundamental, that you know, as everyone here will know, the determinants of mental health do not sit within the a mental health trust. You know, employment, housing, relationships, money are all key factors in that, and that, you know, it was really good to see at one of the early ICS meetings yesterday, part of the work around rehab, really looking at sort of how third sector can support some of the housing aspects of people with long-term long-term mental health needs, and having those discussions as, in a sense, as SPFT just being one of a number of providers along that pathway of care for people, rather than the sort of mindset that's often prevailed in the past, which is that we are the only solution there. So, you know, that partnership working, I know many colleagues, we spent a lot of time working with the ICS, but I think that's really important, really valuable, and I think we're starting to see some of the benefits of that. I think the relationship stuff that you know, in terms of some of the work doing around eating disorders and the acute sector, I think some of that partnership work is really starting to benefit. And I think that we can come up with far better models. I think we come up with better pathways for people, and you know, we recognise that it doesn't all have to be done by the mental health provider in the system. So happy to take any questions, and obviously I think, as you said at the beginning, Peter, I think this is a sort of opportunity to sort of test out the first of those areas around the breakthrough objectives.
Thank you very much, Stanley. That was really helpful. So today we want to just focus on the principles, and then at the end of the conversation, I just want to return to when the strategic objectives for 22-23 might start to emerge, and when therefore the board might need to re-engage in terms of the timetable for that. But can I just ask people to, I mean, Stanley's given us a pretty good summary of the principles that are being applied at the moment. So can I just get any comments on those or additions to those that people feel we should be considering? Amanda.
Just a very quick one from me, Stanley. Thank you so much for that. And you know, I mean, I think I just, as we all do, it really exciting work, and I think it's all about those relationships and building trust, and you know, and that takes a lot of time and investment, and it's always worth it. The one thing I just wondered if it had quite enough emphasis, and I know we've talked about it, but here is in the workforce work stream, number 5, interdependencies. I don't know, just that sense of how, and this is about our vision, I think, for expanding the workforce so that it's, you know, we see it not just as the combinations that we have now, but, you know, I'm thinking about, you know, expanding capacity into the arts and into the third sector. I just feel that needs a little bit more emphasis somehow, that to say graduate mental health practitioners, peer support workers and people working within the third sector doesn't quite express the vision for me in the way that I would like it to, because I think we are thinking outside the box. We do want to have a workforce which is much more diverse, you know, drawing it from all sorts of people and places. And that sense, I think, for me, is not quite in there.
Yeah. Okay. Stanley, if it's all right with you, I'll take a couple.
Yeah, that's
and then
fine.
let you. Is that all right? We'll group them.
Yeah, no, that's fine. Yeah, no.
Amanda, please.
Thanks, Peter. And actually, that's really helpful to do that, because my point is quite similar to Anna's. Thanks, Stanley, for this. Really welcome the focus on partnership that's in here, and a really central emphasis on that, which is great. Particularly picking up, you know, what you're saying there about prevention and early intervention and the role of the third sector. And I guess it's very similar to what Anna said. My point was about, you know, how can we really be clearer on what we mean by the third sector, and that we're not necessarily talking about other health providers in that sector, and thinking more widely around arts, heritage and other opportunities that can be really helpful to us and to them in working together. And I wonder as well if there's something in here. I know we're coming on at a later stage to do some further work on the strategy for Heads On. But again, I think whether there's opportunities we could be picking up on in a very focused way there as well.
Lovely, thank you. Anne.
Yes, I think anything that moves us away from days where people are taken from their communities, cured and then sent back, that it's expressed in the way this is fantastic, and it's heartwarming. I noticed that you said that co-production is at the core, and I still wonder, for those of us who aren't perhaps familiar with the mental health system and people we're trying to talk to externally, if we could almost have examples of a pathway that used to be with timescales and agencies involved, and then a pathway that we see that will be created in the near future, and who's involved in what partnerships and timescales against that. I wondered if that would possibly be a more accessible way, or a piece of work that the co-production section of this work could produce to make it very accessible, the change and the vision. I just wondered if that might be a helpful question.
Thank you very much. Stanley, I think 3 is enough, don't you? Integrate.
Okay, thank you. Well, I'll probably group the workforce ones together. I mean, I think it's a really helpful challenge, and it's one that I think from a board point of view to keep on with, because this is a key issue for us. I think firstly would say that I think we're probably starting from, what we want to do is obviously build on what we've got, and I think that and what we're going to need is more of what we've existingly got, but we're also going to need something very different as well. So we're expanding out. So a number of things really. We're expanding out the capacity. So we're starting to look at this on an ICS-wide basis. I think up till now we've only ever we've tended to recruit on an SPFT basis. So we're now starting to build some capacity in the ICS to start looking at this on a wider basis. I think we've traditionally looked at the recruitment from the NHS agencies, and again in our discussions now we're starting to look at this in terms of how do we bring back the recruitment requirements that we have from our broader third sector partners and also the NHS partners. So again, that's sort of starting to happen. I think the 2 other bits of it to sort of flag, I think, is that one, the pipeline, and again,
we've lost you, Stanley.
In starting to better understand, that is our pipeline of new roles, so that we can see that. And then I think the real challenge and the if you like the transformation bit is, so what people are out there, what are the skills and expertise out there, and how can a whole range of people with different skills, backgrounds, experiences actually work at some part of that pathway of being a mental health provider. And I think that's going to be the challenge, because the traditional roles are not there in sufficient numbers. And we do have to say what is there and how can we use that. And some of that is whether or not there are loads of graduates that we can use in different ways, but also people with very practical skills or working in a range of different sectors. So in CAMS, we're recruiting teachers into some of our services in some of our roles. That feels quite radical traditionally in an NHS setting, but I think some of the suggestions about using people much more from the arts, using people from other sectors is where we need to go, and I think we recognise that. But I think there's a lot of work still to be done on that. Gavin may want to comment on that in a minute. Just the other one on the co-production, which is absolutely right, and I think co-production is not something that nervous about, but I think the co-production has been really good to date. I think one of the things we have to is in my mind, in terms of being cautious about, is that when we try to move things as quickly as possible, there is always a vulnerability that we lose some of that, and I think we've really got to keep alert to that. And I think that's something certainly that I'm very cited on and have been having discussions with people about. I think the concept of an old and a new pathway, not just in terms of what happens to people along that, but actually who's involved, I think is a really interesting way of framing it, because I think any way that we can articulate and show the change for different audiences will be very helpful. So that's something I'll take away and look at.
Thank you, Stanley. I'm glad, because I also think that's a really helpful way of keeping people engaged in what will keep time. Sam, I've got you signalling, so I'll come to you and then I'll do an interim summary.
Thank you, Chair. I suppose just in my capacity as Chair of the Mental Health Collaborative and the Integrated Care System, I just wanted to add to the point Stanley's made. So I think for us as a trust, the development of our adult community mental health teams is one of our key breakthrough objectives. It is one of our 5 breakthrough objectives this year. And having just looked at the summary of those breakthrough objectives, this year is really about designing the pathway, setting those out. But in my capacity also as Chair of the Mental Health Collaborative, of which we had third sector representation around the table, there has been, I think it would be fair to say, a sense from the third sector about, so when are we going to see the tangibles? When are we going to see the expansion in the third sector and the workforce? And I think that's reflective of the fact that we've been in a planning phase, probably for the last 3 to 6 months, quite intensive. We're developing a business case, developing the model. We're now moving into the implementation of that, and that will require us to have really clear focus internally on our part of that, but through the integrated care system and the collaborative, working alongside the third sector and expanding their services as well. And our director of our mental health collaborative, Colin, has been meeting with the third sector leaders through the collaborative, but really scoping out what would a more creative workforce offer look like? How could we recruit together? How could we train our staff together? And looking at whether or not we can be very clear and explicit about the percentage of funding we're getting for these developments into the integrated care system that will be going to the third sector. So as Chair, I just wanted to really assure the board that we're doing that work.
The more of the interconnections we can pull together, the better. So Stanley, I'm going to attempt a summary of the conversation. So we're very supportive of the vision, and we're very supportive of the progress that you've outlined towards the breakthrough objectives for 21-22. I think you've heard a conversation about whether we could be a little bit more explicit in bringing alive our vision around the future workforce and how we bring wider voluntary community sector into our notion of the workforce, but also how we can get skills into wider civil society, and particularly through things like arts and heritage organisations. A suggestion of a conversation around heads-on and the extent to which heads-on can also contribute to the prevention agenda and help with some of that wider community transformation piece, and the desire to see a little bit more co-production, but also I think building on what Sam said about the tangible benefits and the percentage of investment shifting, perhaps it would be helpful at some point to sort of see the pathway now and what the pathway would look like in the future, because I think that's a way of making it explicit both to us and to our wider partners. The paper states a desire at some point to start thinking about the strategic objectives for 22-23. When would that be at a point when the board could re-engage with that in an appropriate way? I want to allow enough time for you to get on with the 21-22 work, but when would be the right time to start to have a strategic conversation about the 22-23 objectives?
From my sense would be, I think we're talking sort of autumn time, aren't we?
Right. Okay.
I think that's realistic. I think we're talking, yeah, I think before Christmas, but I think what Department of Health traditionally would have called late autumn, I think.
Ah, well, okay. So sometime between now and next April. No, to be serious. So as I say, I mean, these are strategic reviews.
Yeah.
We don't want, we need to, we've agreed the breakthrough objectives, we've agreed the direction for 21-22, and it's just then when do we come back and have a look at the vision?
October, November, yeah.
Fine, lovely. Anything else on the community transformation paper today? Well, thank you, Stanley. That was really helpful. And as I say, we really wish you well with the implementation of that, and look forward to coming back late autumn to do our second strategic review of this theme. Thank you very much. Can I now move us to the redesigning inpatient services in East Sussex? Sally, really exciting.
It is, thank you, Chair. So the paper today is just another step in the process, but it seeks to update the board on where we are with the scheme, and then also seeks approval to progress to the pre-consultation business case, which will go via the CCG governing bodies and then out to public consultation. But just to give some context around this, just to remind the board that we last looked at this back in January. This is part of our Eradicating Dormitories programme, in the knowledge that East Sussex has one of the highest numbers of beds in dormitories in the country. We set out on this piece of work to re-provide the whole of the estate inpatient estate in East Sussex, but we've narrowed this programme down to the replacement of the Department of Psychiatry, which is on the District General Hospital site in Eastbourne. We've been working really closely with NHS England an improvement on this, and we've successfully completed the stages 1 and 2 of their assurance process. And in the context of the Eradicating Dormitory programme, we've now secured 46.7 million to replace the Department of Psychiatry, which will be part of a longer term phase development to provide the whole of the inpatient stock onto a single site in the longer term. We've met with NHS Capital because we had to give the assurance that, one, we could complete the scheme within the level of funding, but also to complete the scheme by March 2024. They were impressed with the work we've done so far, and they've ring-fenced the money for the trust, but that will be subject to the completion of a successful business case. So the ask today really is that the board gives us permission to take forward the pre-consultation business case, as I said, through the CCG governing body and then out to public consultation. The paper you have today has the executive summary of the pre-consultation business case, but for brevity on the board papers, the whole set of papers that supports that is set out in the reading room for the whole of the board, which really importantly includes the equality and health equalities impact assessment for the move from the Department of Psychiatry to another site. And in the pre-consultation business case, you can see there's 2 sites identified And we've done the work to really work through what the health inequalities impact assessment would be. Really positive work on that. We've drilled that right down into travel time, looking at public transport, links to the two sites, and working with the ICS on that. It's a joint piece of work. The impact assessment was really commended, and it's one of the best they've seen. So just to give that assurance that the full papers are not here, but they will be part of the whole of the pack that goes out to public consultation. So happy to take questions on that, and really just to note the update and seek the approval to progress to the next stage.
Okay, well, before I open it for questions, firstly, I think we should just congratulate you and those involved on getting us through the various hurdles. I mean, this just happened. This is just good news for patients, and I think the fact that the equalities impact assessment is so positive. Well, both you've been commended on the process, and the outcome of that impact assessment is very positive. Is really palpable. So thank you for doing that and for getting us to here. Are there any questions for Sally or comments? Dan, please.
Thanks, Chair. It's a comment rather than a question, and I guess you'd expect me to say this, but we know from the research that poor communications and engagement is one of the factors associated with problematic change programmes. I just assure the board that there's a robust communications and engagement and consultation strategy that we've developed with our commissioner partners that underpins the programme.
That's fantastic. Thank you very much. So my sense is that the board supports the recommendation that the PCBC should progress to the CCG governing body and then from there to public consultation. Really do commend you, note the progress since January 2021 and the work required to finalise the PCBC in the consultation document. And it's really good to have that reassurance that we are thinking in a wider sense about how we make sure we continue to engage the wider public. And we are looking at the implications both for patients and carers, but then also the wider public around the potential sites. That's approved. Thank you very much.
Thank you. And sorry, I should have said, actually, Dan, you reminded me that there's a briefing ready to go out to staff involved today, and that will go after the board. So
brilliant. Could that go out in the weekly briefing as well, please, just so we get to see that? Thank you. And we're going to set up an estates task and finish group, aren't we, just to monitor the various estates programmes through to the autumn. But we'll bring that back to next board. Okay, thank you very much indeed. Can I now move to the committee reports, and can I start with the Quality Committee, please, first?
Shall I just kick off? I'm sure Acacia and Stanley will want to come in, but just to sort of start off. I mean,
why not?
Take the report and the appendices as read. I suppose I just want to kind of reiterate that this committee is there to very much enable the board to obtain assurance on standards of care and to promote the triple aim. And I think, we have such a vast agenda at this meeting. I think the key things that just to draw to the board's attention is the, very comprehensive update we received on Lindridge, and we agreed to cease the enhanced monitoring on the basis of the work that's been done there. We received again a very comprehensive update on the Langley Green situation and an update on the enhanced monitoring that's going on there. And then we looked at the waiting list management following the RSM audit, looked at the priority actions that had been put in place. We reviewed the reports from the provider collaboratives and the Sussex Family Eating Disorder Service, looking at the demand and capacity issues there. And you've got attached to the report, which Stanley might want to comment on, the work on infection prevention control and alignment with the 10 standards. The one thing I just wanted to highlight in addition was a really fantastic presentation we had on a quality improvement project from colleagues from the Bedale, I think it's Bedale Centre, which was all about better engagement with carers. And it was a fantastic presentation, really positive, and I think it gave the committee a kind of a really good role model for that kind of work. So you know, really encouraging, and want to see more of that. You know, when we meet as a quality committee, in addition to, you know, the assurance work that we do. But that's all from me.
Okay. Thank you very much, Anna. Okay, Kozia, was there anything you wanted to add?
If I may, please, Chair, just a couple of things to build on everything that Anna's set out. So the quality improvement plans and the objectives for Lindridge, I mean, the committee really noted the positive change there, and in particular addressing some long-standing issues around recruitment, so our clinical leads, registered nurses, pharmacy, etc. So we have stepped that down from enhanced monitoring. It's back as it should be in terms of CDS oversight. And it might be helpful just off of the back of this update, Stanley, to give an update in terms of the longer term plans for the Lindridge because we also touched on those, so it might be helpful for board. In terms of Langley Green, we went into a lot of detail around their improvement objectives, and particularly framed around sort of quality improvement. So what's the control, what's the assurance, but actually what's the impact in terms of some of the feedback and the immediate response that we had to their last inspection. And as Sam mentioned earlier in the Chief Executive's update to the board, really positive that the re-inspection of the service is demonstrating that improvement to the Commission as well against the update that we received. So good to see that being progressed. In terms of Langley Green, though, we touched on at the last board meeting the challenges that our acute services are facing as it relates to acuity. So I just want to flag that it's really positive to see in the community transformation report the focus work around the mobilisation and business case for complex trauma and EUPD specifically. You may recall, and it would have been a while back now, but through the Quality Committee, we've had a number of discussions about the care pathway for people with, who have experienced complex trauma or EUPD, and that was certainly a feature in terms of some of the acuity that our teams are having to deal with. So it's good to see that progressed in the read across. And then just very lastly to say that we had a helpful update in relation to the waiting list management. We moved away from focusing on the sort of system process assurance to focus much more on people's experience, quality and safety, and received an update from Stanley and the CDS leadership team in terms of the review and triage of waiting lists, and specifically how people are contacted when they're waiting and how we're able to step up or step down contact as needed. So those were the couple of extra areas I just wanted to draw out of the report, but overall a very comprehensive, detailed committee. Don't know if there's anything you wanted to pick up, Stanley.
Probably if I just in terms of Lindridge, and I think I mean it's really good. We've got a strong clinical team in there now, and I think picking up on the work out in the wider system, there is work going on in terms of out of hospital beds across the sort of Brighton and Hove area, and Lindridge is playing into that as part of that wider option, and I think it's very much sort of learning post-COVID to bring together a much more structured approach to the out of hospital beds. So we're working with partners on that. Obviously, Lindridge provides a service for a whole range of different groups. So our input is we have a number of, it's not as straightforward as some of the perhaps might seem, but we're working with partners to hopefully support the system in a way that enables better use of out of hospital beds. I think then just in terms of the waiting list, and I think just pick up on the waiting list item, I mean, this is a substantial piece of work. This is a program for us as an organisation. I think the work around the data cleansing in terms of being clear what our waiting lists are, and then breaking that down into sort of two key bits. It's the waiting lists from people from outside the organisation, and then obviously being really clear on our waiting lists internally and how we're managing and supporting people as part of that. We will need to be and will be looking at a revised approach in terms of how we manage that waiting list and the sort of system that we need to do that, so that we've got consistency across the organisation.
Good, thank you. So are there any questions for Anna or Akosia? Could I, while people are thinking, could I just ask around, we talk quite a lot, Akosia, about increased levels of acuity, and you were talking about the need to bring in, you know, skills around just making sure we've got the focus skills around complex trauma and EUPD. We quite often talk about safer staffing, don't we? Which is a sort of which is about numbers. I mean, are we confident we have got the right mix of staff when we're looking through the different lenses we now need to look through?
So a really good point. Thank you for that, Chair. I think in terms of numbers, we have that. So, you know, do we have the right number of staff to be able to support patients across our inpatient service provision? Absolutely. I think, however, given the change in profile that we're seeing, so an increase in admissions of people with complex trauma, EUPD, that does require a slightly different skill set. So it's much more about the skill mix. And for me, it's about how allied health professionals, psychology, medics are working alongside the nursing teams and our support staff to really provide the best possible care. The other element, I think, to draw into this, and the point that I was making around acuity, is that for people with complex trauma or a diagnosis of EUPD, admission to hospital increases the level of risk, and therefore for our staff within those settings, they're dealing with more acuity, they're dealing with more risk. So I think there is something about the skill mix as it relates to the community provision, so seeing that in the community transformation and along that urgent and emergency care pathway well before somebody even comes into hospital. And then that needs to be supported by programmes of work and training skills, competencies in relation to DBT and MBT and STEPS, and how you manage care in a safe way in that context. So I think we need to move it away from numbers, would be my view, and from the skill mix within inpatient services to really starting to think about what are the skills and capabilities and mix that we need within community provision to really support some of the most complex clinical needs. Okay, thank you. Stanley.
Thanks very much. Yeah, I was just going to sort of follow up on what Cody said about the skills. We do have, historically, there has been differential commissioning across the three different areas of Sussex. And so the levels of investment in community services is different for those areas. And as part of the work around the sort of broader long-term plan, with the investment that's coming into the service in relation to working with people with EUPD, it's taking into account some of that differential commissioning and investment, so that areas that have had or less investment are the areas that we'll be prioritising first in terms of where we're targeting some of that investment, and that will be reflected in the business cases that are being developed, so that we have more consistency and we are able to provide more consistently a similar approach. And I think, you know, as very much as Cody said, it's very much about getting that community provision right, so that we can manage people in community settings, because inpatient care, you know, it increases the risks.
Thanks, Stanley. I've got Rick and Sam, so I'll come to Rick first, and then I'll let Sam have the final word.
Thank you, Chair. Just to say, I think Akosia is spot on with this move towards community interventions for this group of people, and looking further upstream as well. Dare I say, it is also about prevention and working when these kind of problems are starting to emerge, and that's where I think we're going to be focusing more and more, and that means working across with partner organisations as well, and, you know, third sector voluntary organisations, so that we can make sure that people have, when they have emerging emotional difficulties and it hasn't become a full, medical condition, a personality condition, a disorder, that then we can work to prevent that. And there's some good models out there that we're looking at to really, move on that.
Good, thank you. Sam.
Yeah, thanks, Chair. I've got sort of 2 points really, but not connected. The first one relates to the discussion we're just having, and I suppose the point I wanted to make around the 3R framework, the recover, the reset and the restore approach that we've put in place across the organisation, the particular task and finish group we've got on waiting lists, which is about the waiting list management, the standards we've got in place, consistency and reducing variation. It's a really important piece of work, it goes without saying, but we're also doing this at a time where we're recovering some of our services, and we've spoken about the pressure on services. And I think your question about safer staffing is a good one. It's a very dynamic process that we're in, and I think as we do the piece of work around that waiting list management and standards, but also respond to the pressures and services, we need to be really supporting our services in terms of up-to-date, accurate assessment of the risk and the mitigation of that. So a good example of that will be in our children and young people's pathway, and any immediate changes that we need to adjust in terms of staffing profiles and levels. We've got a very robust system in place, and absolutely content we've got that, but it is a dynamic situation. And as we come out of Gold Command, we've got no COVID-19 positive cases across the organisation. We are establishing our recovery board that will keep that under close review as we recover the situation. The second point, it's just relates to the update, and I wanted to recognise the work that's been undertaken by infection prevention physical health team, particularly around the learning from the COVID-19 outbreaks. And it was a question really, we're obviously all hoping that there won't be a third wave, and we're watching. That's a dynamic situation, particularly with the new variants at the moment, but just really keen that we get the learning out of those outbreaks out across the organisation as soon as is practical, really. So just a sense really from the committee when we're looking at doing that.
Thank you. Akosia, and then I'm going to try and summarise.
Okay.
Thank you.
So I'll pick up the piece around the learning from outbreaks, but just to say for the safer staffing piece, the reviews, because it is so dynamic, the reviews for inpatient services happen annually. So they're underway now, actually, and then outside of their daily huddles to look at what they do need to be able to deliver. And that isn't process, that isn't about numbers, that's about what are the themes from SIs over the last year? What are your lines of sight? So that is really, really important. I do think, though, and I'm going to go back to community, we need to be looking at the safer staffing profiles for community services, and perhaps looking at that through the same lens through which we do inpatient services. And I think that will help with some of the pressure that we're seeing on acute services and the pressure that places on staff. So that's the staffing piece. In relation to the IPC Board Assurance Framework, so it is appended for the committee detailing all of the progress. In relation to reviews underway, so just for clarity for the board, whenever there is an outbreak, there's an outbreak management group that meet with the local units. So any immediate learning is pulled into practice, and then any learning from the previous outbreak pulled into that as we have them. We don't have any at the moment. The initial themes and learning have already been shared through the Gold Command and through Silver Command, where the IPC and physical health team take that there. What we've been doing along with all other organisations is making sure that we have the RCA, so root cause analysis reviews undertaken, and we're progressing those well and to time. 67% of those are complete, and with their conclusion, the themes and learning and any change to our IPC or practice will come through the Quality Committee and then to the board. So that should be August committee and then onwards journey to board. I hope that's helpful.
That is helpful. Thank you, Akosia. Okay, well, thank you. That was really, really helpful. So we note the summary that was provided by the Quality Committee, particularly in terms of the improvements at Lindridge, the progress at Langley Green, the updates, particularly on the FEDS action plan, which we referred to earlier in the meeting, and the work that's going on in terms of waiting list management. I think it's particularly interesting to hear about the work that's going on to look at staffing profiles within community services and the business cases that are being developed to support the development of the community workforce, and indeed, of course, the increased focus on prevention and managing people with complex needs in the UPD in the community as much as possible, in terms of that being a more progressive model. But we recognise that's in the context of the 3 Rs and the need to think about the pace at which we can go in terms of recovery. So thank you all for that. We note the Infection Prevention and Control Board assurance framework, and we look forward to, I'm sure these issues will continue to come to us through the Quality Committee in coming months. But thank you very much for that today. Can I now move us to the Integrated Performance Report? Stanley, you may assume that we've read it.
Thank you. Okay,
I hand over to you. Thanks.
Okay, thanks very much. So what you've got is the March Integrated Performance Report. I guess just to sort of highlight, if you like, the work in progress on this report. So the approach of actions, monitor, achieve is one that is now embedded, and the linking in of the Trust Core standards. For the next report, or for the July report, we'll have done further work around triggers as well. Some of the thresholds need adjusting. So you'll note sort of reds where there's very little threshold between red, amber and green on some of the targets. The other thing we want to sort of build in here as well is that the CDS assurance process. So we've now established a monthly process of assurance process with our CDSs as part of the performance management and monitoring of this. So we'll be building that in to the report as well. The report doesn't show much change in terms of 7 achieved, 2 monitored and 15 red action, 15 for action as yet, but the report I think is more robust, and I think we've done a lot of work around the recovery and aspects of a number of these targets. So we've broken that recovery down by CDS. So again, there are across the organisation 44 developing recovery plans for that. Within the report, you will start to see timelines now appearing behind which are those recovery plans. So in the report, we've particularly focused on the ones that are a priority. So we're trying to focus on those that relate to quality and risk. So the physical health one, we now have targets. The risk assessments, care plans and appraisals are some of the examples of those where we have robust plans that sit behind that and have identified targets in terms of when we will be achieving that. I think there's just a couple of themes I want to draw out from this. I think firstly, the pressure on beds affects a number of things. It affects obviously our out of area placements, our privacy and dignity, and our agency figures are affected by that. And then I think just in terms of COVID surge areas, as described, so significant pressure in terms of our CAM services, children and young people services, and also, as we touched at the beginning of the meeting, around some of our areas around ADHD and autism as well, are features of pressure coming into the service as we move from one stage of the COVID pandemic to another. Just a couple of other points to note. Firstly, in terms of training and our reporting and the challenge around face-to-face training, and I think we'll be sort of reporting that slightly more separately around the face-to-face training and the online training, because our ability to do the level of face-to-face training that we were previously able to do, I think, is slightly diminished. on that. So that's having an effect in terms of when we're likely to be able to complete that. And obviously we're looking at ways in which we can either expand capacity or do that in a different way, but still meet those requirements. I'll pause there and happy to take any comments and questions from colleagues.
Okay, thank you. Questions for Stanley? I've got Anne and Anna and Nitin. Thank you.
So just to say, it's a simple question, and I'm not sure it'll be a simple answer. In the target, Stanley, we have target of 0 against 2,270 bed days that we, in addition to the 45 patients that we've got beds for locally. And with factors like delayed transfer of care, you know, we've got 97% bed occupancy at the current time, but it's been a lot higher. And then, of course, all the impact on finance is discussed at audit and quality. Why do we have a target of none?
So should I pick that one? So just on the beds, our target is to operate within our 45 contracted beds that we have with the Priory Group by the end of September. So that's our target to achieve that. So that's what our aim is, and that's what we're working to. And obviously that's something that as a board we've committed to that investment. Obviously committed to that investment as well. But that's the target that we're working to.
Okay, thank you, Anna.
Thanks, Chair. Stanley, I suppose I had a couple of just sort of general observations. I mean, first, when you talk about this report being more robust, I suppose I'm just interested to know how you're using it, how it's being used, not just for, you know, reporting purposes to us to keep the board informed, but how it's actually being used in practice on an operational level, and how that's evolving. I just want to get a sense from you of how that's changing.
Okay, yeah. So I'll start with the CDS assurance arrangements and then talk about the recovery plan. So we now have a monthly system whereby we do focused reviews, which is led by execs and performance team, Charlotte and her team, with the leadership teams of each of the CDSs. And from that, we draw out both obviously the key areas in terms of need for performance improvement, as well as obviously some of the key achievements that people have as well. What we have now is a situation whereby underpinning the areas of that we want to improve performance by, we have a number of agreed, signed off plans and trajectories. So for each of the areas, for each of the services, some of them still require improvement, but we have plans in place. We test out those plans because we've committed to dates that we think we have the capacity, we have the time, and we are able to deliver on those on that. So we are taking sort of actions like community teams. We are taking people out for a day to do certain things around care plans, around training, around risk assessments. We are maybe making changes around some of the administrative arrangements, so some activities are being taken off people so that they can focus on some of the core clinical requirements that they require. So that we have that monthly system now of monitoring that. Plus, I believe our plans are much more robust and resilient. We are then monitoring that through our executive management team. So this month we focused on the high, if you like, what we see as the critical areas, some of those being about physical health, supervision, appraisal, and what are the blocks and obstacles in our way, and trying to get prevent, obviously that there are many reasons why people can be drawn away from doing, things like supervision, appraisal, training, and we've got to build in structures that allow people to do that routinely. So that's when I talk about being more robust, I think that's what I'm talking about in terms of having confidence in the recovery plans that are being set to do this.
That's really helpful, because I think what I'm kind of getting at is that it strikes me that so many of these, the narrative on the impact of COVID, I wonder if it's prominent enough, because I think there are some things that are possibly less to do with the impact of COVID and some more, and I almost feel like in the narrative that needs to kind of come out more clearly. I mean, maybe this is not the place for it, but it just struck me when you have, flatline or actually a downward turn in whatever your metric, you want to have a robust and clear narrative as to why that's happening. That's really what I'm getting at, and whether we have that front and center. So yeah, just interested in your thoughts, really.
I mean, I think there's it's not difficult, but there is a balance between recognizing that you have a workforce who have been through an incredibly difficult last 15 months, that physically, psychologically, hugely challenged in terms of what they've had to go through, that at times that workforce is, if you say on the edge, not wanting to overstate it, but I think that, I think people can all, from wherever we sit in this, feel that sense, because this is a time when people have not only experienced it at work, but they've had it at home, which has been traditionally been their point of respite in terms of the sort of work demand, and then balancing that with what is reasonable to expect of people when faced with those challenges, and how hard do you push. But I think in part, and that's why I think we focused on the critical ones around sort of quality and risk, is that everyone would accept they still want to focus on those. I think you might have a slightly different view if you talked about clustering as your main priority, but we're not talking about clustering as our main priority. We're talking about supervision, we're talking about appraisal, we're talking about training, and we're talking about the physical health care of our patients. And I think everyone does that. It's then incumbent on people like myself and others to come up with structures that free people to be able to do that in a way that doesn't overburden them.
Yeah. Okay, Sam, did you want to come in on this point? I'm conscious I got Nitin in as well.
Yeah, I mean, just briefly, Chair, I think, Anna, again, your reflections are really helpful. And I do think, we're taking the integrated performance report, it's a sort of iterative continuous improvement. And I do think there could be things we can do to pull out the particularly COVID related pressures. And also at our the next iteration of this, we'll also have the breakthrough objectives included in here and the report against the metrics. What I can say though, so the Executive Management Committee looks at the integrated performance report every month. At our last meeting, we did a deep dive on 3 of the indicators, and we used our board risk appetite around low tolerance, around quality concerns, to focus on the indicators, looking at care plans, risk assessments and supervision, but also looking at the work each of the care delivery services have put into their recovery trajectories. So our new integrated performance framework that Charlotte has created, we've signed it off through the Executive Management Committee. We've been through 1 round of those meetings with the care delivery services, and there are underpinning recovery trajectories against all of these targets, and we'll continue to build on those and share the practice, because this is an aggregated position as well, and with several care delivery services, some of their issues are a bit different. And I think one of the things we could do also is bring through to board an overview of the sort of mitigating actions that those assurance meetings are putting in place as well, so that you can see the connection with the improvement work.
Yeah, I think perhaps if they're quality related, perhaps they could come to Quality Committee first and then come through to board if necessary. I suppose I'm conscious, Nitin, that you're being very patient with me. I suppose, Sam, there's also the fact that we spent a lot of time between this board and the previous board looking at things like physical health assessments. And when we look at the effective domain, we clearly have some issues there. So we do need to make sure we understand what some of the underlying drivers are.
Yeah.
don't we, given the focus that there's been on things like that. Nitin, you've been very patient. Thank you.
No worries. I just had a couple of questions. I think for the physical health assessments, having read through, I understand a lot of it is COVID related. What I wanted to understand was the clustering and compliance. Again, from what I read, I think that's being phased out. So is that going to be a metric at all going forward? Or do we care about that going forward? Should I? And yeah,
So the clustering, it will be changed to something else. So the clustering will change to something else. So although the language, there will be some other way of grouping and bringing that together. I think that in the way that physical health is very clear in front of you that this is important, I do think clustering is important as well, because we need information to drive and inform what's happening in our services. And the better we can use information, I think it's fair to say that we have the way in which the indicators, the way in which we collect that information, we need to do, and I started to do work in terms of improving the systems that we need and a consistent system around that, and particularly the accountabilities and responsibilities around that. And certainly it's an area, clustering is a good area where actually as part of the first round of CDS performance meetings, I think we highlighted some aspects of recording that we hadn't appreciated were impacting on how that target is recorded. So there was learning in there for all of us, but clustering will change into another form. And as I say, I think it is important in terms of us understanding the service that we're providing and who we're providing it to.
I think that's something we can expand a little bit offline. I want to move on. I've got Charlotte, and then I'm going to move us on.
Thanks, Peter. I think Stanley's picked up what I was going to say. Actually, you're going to come in on clustering. Thank you.
Okay. So, thank you. I mean, I think the integrated performance report is really clear. Really good to hear that, yes, the breakthrough objectives will be reported through the integrated performance reports. I think that will keep us focused. I think, Stanley, I think the questions about what the drivers are is really important. And I think if we can, particularly those in terms of the 3 R's and those that are really important in terms of making sure that we're getting the basics right, it would be good to understand what's driving some of the variations. And I think we can bring that through Quality Committee. So thank you very much for that today. And clearly some of these are issues we will inevitably return to, but thank you for giving us some confidence that you've got the plans in place and that we're trying to get on the right trajectory. I need to move us on. I'm going to move now to the Finance and Investment Committee, please.
Thank you, Peter. I hope that I can take the report as read. I just wanted to draw attention to achievements, lack of complacency, and then move on perhaps to Sally for the latest updates. The achievements are there for all to see on page 5 of 6. And I know this goes across the trust as a whole, but under key issues and risks, I think the key successes as listed and agenda moving forward and historically are worth noting and drawing attention to. But if you go to, or if I may draw your attention towards the end of the report, and it's predominantly around, Chair, if I may, around governance moving forward. We take very seriously within the Finance Committee the self-assessment that we did. And there was a sense, we lost Nick, obviously, through the last year by way of our committee structure as a non-exec. There was some feedback from our own members that maybe we rely a little bit too heavily on 1 or 2 of the group. And probably more trust-wide than that, we think we need to work as a committee a little bit harder on ensuring that the 3 committees, and F&I plays its full part in that, are fully joined up, whether on a project-by-project basis or in terms of helpful feedback, constructive feedback to the board. So the report, as I say, I hope I can take as read. Some significant achievements and congratulations therefore, of course, to Sally and her team, but by no means complacent. And I would encourage us perhaps to move on to Sally for the latest update on where we are looking forward rather than looking back.
Okay, thank you. Well, I'm sure people would be happy to do that, Sally.
Yeah, thank you, Chair, and thanks for that, Martin. And just to say, echo what Martin said, I mean, as well as managing the response to COVID, we've managed to achieve a number of new developments this year. One of which we've already spoken around with the East Sussex inpatients, but there's many other things in the report that are either work in progress or we've managed to complete, including provider collaborative. So, you know, the work of the committee continues to develop as well as manage the current situation. So if we move on to the month one finance report, and usually there's no report here this month, which is probably a first really in terms of not being able to provide a report to the board in a timely manner. That's due to the fact that the planning guidance was late and we only submitted our plan on the 6th of May, which was a full plan for the ICS for mental health and a half-year plan in line with the guidance for the trust. I have got a brief update on the position. So we've now completed the month one position. Now we've loaded half-year budgets, which again is a first. So we don't even know where we'll be for the second half of the year. So again, we're still in this unprecedented time of the unusual financial regime. But for month one, we had a £300,000 underspend. And I just really wanted to alert the board today, and then as I'm sure we'll discuss later through the year, the balance of the financial position is really trying to drive the business as usual, addressing the key challenges that we've had around beds, you know, and some of the things we've spoken about in the integrated performance report and the pressures on the out of area placements, together with obviously the staffing issues and the continued reliance on temporary staff with delivering the transformation programme. So I think actually the financial performance, even though it comes a lot later in the agenda, really does speak to the things we've talked about, because the key thing will be delivering the community transformation agenda this year to take the pressure off the inpatient services.
Yeah.
And just to say, we've got a finance investment committee on Friday, which will go through the full month one position.
Okay, Sally, thank you very much indeed. So, I mean, thank you, Martin, for the review of committee effectiveness. And it's really good to see so many positives, but also some areas for development. I think that shows maturity in terms of that self-reflection. I think, Sally, I think the way you've outlined the need to focus on the investment in community transformation and getting that as best as possible, get those business cases through and get that investment in place is really important. And clearly that's been a theme right the way through the meeting. Is there anything else we need to do today on the finances? I mean, we note the fact that the annual planning guidance was late, and so clearly we are in relation to that. Is there anything else we need to pick up today?
No, nothing more today, thank you.
Nothing more. Are there any questions for Sally? Nope. Okay. Thank you very much, Sally. If I could now move us to the Audit Committee, please. Hello.
Hello, I'm not quite sure what happened there. Thank you, Chair. I take the report as read.
Yep.
But I would just like to draw your attention to pages 9 to 10, the key initiatives undertaken by the Audit Committee during the last year. As you'll see, there was quite a strong focus in governance terms, particularly on COVID and its impact. But that apart, we also focused on all the other areas that are highlighted in the report. And so any questions or any points anyone wants to raise?
It would appear, Sam, please.
Just briefly, Chair, just say as accountable officer of the organisation, I had the pleasure of attending to observe the Audit Committee yesterday, although I did contribute a couple of points, and I was just really...
You were invited to contribute.
Thank you, Chair. Thank you, Chair of Audit Committee. It was just a real pleasure actually to hear the reports back from external internal audit, and I think particularly what you're drawing our attention to here, Joe, in terms of the work of the Audit Committee. And I think as a board, as a committee, not shying away from some of the more challenging areas, particularly particularly where we can utilise and draw on the skills for additional assurance and where necessary, support with improvement from both our internal and external auditors.
Thank you. And Chair, if I may, just as a final comment, first of all, thanks to Sally, Corinne and the finance team and the amount of work that we have done over the year and the amount of effort and flexibility they've demonstrated in working with Amanda, Anne and myself. And then over and above that, I think that, again, I think that the purpose of having the audit committee, I mean, when I've just been chair just over a year now, and I remember saying to Peter when he asked me if I wanted to be audit chair, I'd have no thanks, but I'll go away and think about it. But in fact, I think that over the last year, and particularly coming into the role as we went into lockdown, it has been an exhilarating experience. I've learned a lot, but also it's been terrific working with Anne and Amanda, for whom coming in and joining a main board committee and not meeting or knowing anyone within the group. But somehow we've really put the effort in and created a much more strategic focus in terms of the focus of the work of the audit committee. And finally, I think that in terms of the alignment of the committees, I think that audit committee and quality committee have really now got it working very well. And I was going to comment on the waiting list management internal audit, but I think in fact that's been covered really quite effectively, and there's nothing more that I need to say on that.
Okay.
So that's all from me. Thank you.
Thank you, Joe. I mean, I also observed the audit committee, and I agree that I think the focus on strategic issues is really strong, and I think it's a good non-exec team supported very ably by executive colleagues. And interesting, I was going to highlight that I thought today's example in terms of waiting lists and the fact that it can be looked at through different lenses in different parts of the governance system is a really good example of how that's meant to work across the organisation. Quite often audit committees focus on finance, and actually to see the audit committee also focusing on strategic quality issues is really, really good. And thank you for the work that you've done as chair, but also to Amanda and for the support I know that they give you, and to Sally and her colleagues for the work that's done to support the audit committee. Thank you very much indeed. Are people happy to move on from the audit committee report? Yep, they are. Okay, thank you very much. Can I now move to Appointments and Remuneration Committee annual report? I'll take that as read. I wasn't proposing to add anything to that unless anyone's got any questions. Okay, so we'll approve that. And then Charity Committee report.
Thanks, Peter. You'll have received two reports from us. First one, the report based on our most recent meeting in March, and then the Charity Commission annual report. On the first one, I guess one of the main things we discussed this time was really giving thanks and passing on our thanks to Rachel Duke and the team. It's a very small team, as you know, in Heads On, and it was essentially decimated for a number of reasons across the last 12 months. So really we recognised all the hard work that they had done with a very, very small team with staffing shortages, which I'm glad to say have now been addressed, and we have 2 additional recruits to the team, which is fabulous. We talked about and looked at progress against the business plan that was extended to September 21. Also noted the work that Rachel and the team are doing in developing the plan to 2025. And as I mentioned earlier on, looking forward to doing some board strategy work in July, really to talk about the potential and the future potential of Heads On and its relationship with the trust. Some of the nice initiatives that we recognised was particularly the Hearts of Gold progress and the engagement with 80 schools across Sussex during Children's Mental Health Week. Rachel and the team understandably very proud of that, and very proud of the awareness and the increased awareness regarding mental health that achieved. Also, I'm particularly struck about the work that Rachel's doing with NHS Charities Together, with charities in the Southeast, the other NHS charities in the Southeast, and also at national level. And again, I think huge potential there for impact and influence. in those areas as that progresses. The Anya report, the questionnaire was very poorly responded to, but those that did respond, the main themes coming out of that were the need to address some skills gaps on the charity commission, or sorry, charity committee. Also to really make sure that we're giving the right level of constructive criticism and challenge to Rachel and the team. And also a point was raised regarding the integration of the Charity Commission, sorry, I keep saying Commission, apologies, Charity Committee and its relationship with other subcommittees and us as a board. I guess happy to take questions. I guess I'd like to finish by really appealing to colleagues. Please do engage with Heads On as much as you possibly can. Sign up to the its email system, have a look at the website. Lots of brilliant initiatives going on. I know I'm looking forward to doing our NHS afternoon tea together in July. But again, lots of areas there that I think we can really help raise awareness. And as you know, look forward to talking in July. I really think there's a huge opportunity to use the Heads On brand in terms of that opportunity, not just as a fundraising wing, but as something that can really help, as I said earlier, help us reach out at community level in relation to impact and influence and prevention.
Thanks, Amanda. Thanks. Good. So very much note the comments you've made about the year past. I want to thank Anne Beals for the time that you spent chairing the committee in the past year, but also to you, Amanda, for taking it on. We will bring the strategic overview of Heads On to a discussion at the board in the near future. So I very much look forward to that, and we'll accept your invitation, Amanda, to look at the website and make sure we're familiar with the various initiatives. Thank you very much for today, though. Can I, so that's approved. And now if I could move to the board assurance framework and ask people to, I suppose, stand back and just check that they're confident that we've captured the risks to the delivery of the breakthrough objectives accurately. We will very much be using the board assurance framework to set the flight plan for the board for the year ahead. So can I just ask people to say whether or not they think that, yes, this does capture the key risks, or if there's anything missing? I think people are happy with that. Well, the proof of the pudding will be in the eating as we seek to use it to set the flight plan. But can I thank the team for pulling this together? It's a significant piece of work, but doing it well it really does pay off. So actually having a BAF that you've got confidence in and that actually does capture the key risks that you can then use to drive the board agenda is incredibly useful. And I know the Audit Committee will be looking at the mitigations in more detail in the months ahead. So thank you very much for that. Are there any...
Sorry, Chair, can I just mention one thing? Sorry, I should have come in on the BAF. And we've all been involved in updating this as well. My one reflection is we have no gaps in assurance identified, and I think that might be, that might be a positive thing. But I suppose I was just reflecting, thinking about actually going back and just being really confident that actually we don't have any gaps in assurance, both internal or external assurance. And I'm certainly going to go back and have a look at it with that lens on, Chair.
Yes, well, that's what I mean by asking the Audit Committee to look at the mitigations. So we're on the same page with that.
And sorry, Chair, could I just add then, Sam? Thank you for that, because I think on the having the two things that I noted was the addition of the digital adoption and children and young person services to the BAF. And I thought that's excellent because it just picked that up, and we'd be picking that up at Audit Committee as well. So if there is anything else where it occurs to you, but I was thinking hard about gaps and nothing came to mind, but there always is somewhere. Thanks.
So I think we welcome that, Sam. I think having another look would be good. And I think particularly in light of the conversations we've had today around the relationship between community transformation and inpatient pressure, we might just want to check that interface, and there may be others that come to your mind, Sam. Is that all right? Yep. Okay, thank you. So we then got the Freedom to Speak Up Guardian report. Do we have? Don't have Lynn here at the moment. Shall we go to the sealed documents report, Dom?
We can do, Peter, and this is just the usual sealed documents report for the board to note.
Lovely. Can we see if we can get hold of Lynn?
Yes, I'll call her now, Chair.
Thank you.
Peter, can I just chip in maybe at this point? Just, I don't want to steal Lynn's thunder if we do get hold of her, just to reassure colleagues, she and I did speak today. I wouldn't want to steal her thunder by adding to the report, except to say it presented to me as good progress, plenty of activity, plenty of engagement from the workforce, which is what we want without any worrying trends being identified. If she now joins us, I hope she doesn't contradict what I've just said, but I'm offering that in the spirit of hopefully and maturely filling her gap in case she can't make it for any reason. But we had a good meeting and a good conversation yesterday.
That's good. Let's see if we can find her. Lynn's joining now.
Here we go.
Hello, Lynn.
Hello, Chairman. How are you?
Oh, mustn't grumble. Welcome. What do you have to that you want to highlight to us this month?
So this is the annual review, Peter, of speaking up over the last year, and it's not just to the Guardian, but also to it includes elements from HR and from fraud and those who go direct to the Chief Executive's office. And I think that generally, just to highlight that it's been another good year for speaking up, and that we've had an increase on previous years. So we've gradually seen an increase of people speaking up to the Guardian. In addition, within HR, they have been able to get some learning out of the sorts of things that are coming out of grievances, and in particular the need to pay close attention to applying the organisational change policy or any policy consistently, because that seems to promote the most grievances. And I think it is pretty much as read, really, if people have had the opportunity to look at it. And I suppose really it's to assure the board that actually it feels like the speaking up culture that is encouraging people to feel secure, to raise concerns, is improving year on year. I mean, I won't say we're actually there, because you know, if we look at the staff survey results sometimes and people talk about the amount of bullying that they've experienced, it doesn't equate to what people speak up about to any of us in this paper. So we've still got to get to where people feel more open to have a conversation. But all in all, I think it's you know, been a year that should be reassuring for the board.
Okay. Are there any questions for Lynn? Anna.
Just a quick one. Thanks, Lynn, for joining us, and thank you for your report, which is always fascinating and really important to the work. I just wondered whether you had any comment on the increase in anonymous concerns and what the learning from that was? I mean, it's always difficult to sort of talk generalities, isn't it, when you've got small numbers, but just any thoughts on that?
So from a perspective of the speaking up to the Guardian, there wasn't an increase in anonymous concerns. I think because Sam is so open about allowing individuals to sort of come right into her office if they want to with questions, that perhaps people have a sense of knowing that, you know, generally most people go through a line management route or the Guardian route, and they don't go straight to the Chief Exec's office. But nonetheless, we make that an opportunity for people. So, I mean, I as a Guardian, I'm always personally a bit disappointed if someone chooses to be anonymous, but I think it will always be the case. Surrey and Borders, the other half of my job, had a couple more than Sussex this year. So, you know, it's not unusual. I think it's pretty consistent. And in fact, probably if I went and looked at every other job else, it would probably be better than consistent. So I'm not unduly perturbed by it. I think we would always have that a little bit, Anna.
Okay. Sam.
Thank you, Chair. So I suppose just from my perspective, just to reinforce, I think all speaking up is positive in terms of, you know, we're always constantly curious and we're listening. I think whilst adopting sort of a very open culture in the organisation, we do want people to speak up where they have concerns. We clearly want to support people to speak up within their teams and to have the psychological safety within their teams to raise that. Of course, where people can't, there are various routes people can take. And I'm really pleased in this annual report, we have brought together the concerns that may be raised to my office alongside the speaking up, and that we're sort of triangulating these concerns as well. And certainly I meet with Martin as our Senior Independent Director, where we look at those concerns that come through the office. I know, Lynn, you also have a direct line to both myself and Martin. I just want to mention the review that we've done using the NHSI e-toolkit, looking at speaking up, which has been helpful to do. And just in terms of the executive leadership for speaking up, which I've held, certainly since my coming into post as Chief Executive, I've agreed that that will move to Gavin now as our Chief People Officer, and that what we want to do is continue to build on a you know, positive culture, safety culture in the organisation. And I was really pleased, and I think it's a good development to come out of the past year, where we've developed a partnership with Project Wingman, which is the airline industry who have been in our unit supporting our staff. Given the human factors training, the safety training in the airline industry, we've co-developed with the support of Health Education England what we've called civility training. We tested it out with them at the end of last year, and the first of those courses took place yesterday, and there's another one next week. And based on the evaluation and feedback of that, that will be something we may be looking to implement across the organisation, because I think, you know, to your point, Lynn, at the heart of a lot of speaking up is about relationships, it's about perception, it's about experiences. And the more we can do to support people with sort of civility, you know, in the workplace, at a team level, the less staff-related speaking up we'll have, and perhaps we'll start to see the drift to more patient-related speaking up.
Thank you. Gavin.
Thanks, Chair. And just a couple of points, if I may. Firstly, to Anna's point about the anonymous speaking up, because I'd registered that in the report as well, Anna, and just to give assurance to the board that regardless of whether a speaking up is anonymous or otherwise, we follow those up and do, you know, what we can with the appropriate investigation. Secondly, I just wanted to comment, I think the relationship between HR and speaking up has got even stronger over the last 12 months. And as Lynn has alluded to, I think the learning that we're picking up from a HR and workforce perspective based on the some of the cases is really helping driving how we develop policies and approaches, etc. And the third thing, Chair, I just wanted to comment on grievance, of the kind of number of grievances, because we've seen a slight increase, but I think what is helpful is we're seeing an increasing number being dealt with at the informal stage. So the ability to have conversations at an early stage to resolve issues, as opposed to them going through the full process, which is often very time consuming, and if I'm honest, probably doesn't, kind of please anyone at the end of it. Thank you.
Thank you, Gavin. Thank you. Lynn, I just wanted, I'm not quite sure how we would know, but I suppose do you have a sense of whether we get as many people contacting you from different protected characteristics as other organizations do? Are you confident that we're, drawing people in from different parts of the workforce?
I think I probably could do a piece of work to find that out. When I give people who've spoken up to me, they complete a feedback form that gives me their sort of their ethnic origin, their sexual orientation, etc. That's not readily shared with the Freedom to Speak Up, the National Guardian's office. Right. But it wouldn't stop me asking the question of my colleagues in our South East region to find out if there's any issues. I think from my perspective, I haven't noticed that I have either all BME members of staff or all white British. I think I have quite a good balance of people speaking up, but it would be worth it, but might be a good exercise to do actually. So I'll happily perhaps see if I can find out a little bit more on that. I know there is a push by the National Guardian's Office to try and make sure we have a good blend of speak up advocates that mirror all sorts of different minority strands, and so I think we'd, I'm always conscious of that we appeal through the whole speaking up process to a range of diversity issues in the organisation. But I think I'll perhaps see if I can find out some information on that and report back, Peter, if I can.
Okay. I think I'm just curious as to whether organisations record that and what information is available. But thank you.
Yeah.
Good. Are there any other questions for Lynn? Brilliant. Lynn, thank you very much. And sorry, I called you a little bit early, but thank you for joining us that little bit early. And thank you.
My pleasure. I can't ever get it right, Peter. I'm either 10 minutes too late, 20 minutes early.
Well, I think that's very diplomatic of you, because it's not really you that's not getting it right, is it? But thank you for framing it. Thank you for framing it in that way.
Okay, Peter. Thank you. Bye-bye.
Thank you. All right. Good. So I think we can end the live stream there.